Good morning again. We will go to the next slide presentation of arterial blood gas analysis, or we can say an acid-base balance part 4. Yes, whenever I talk anything on academics, I put a big salute to the legendary teacher of 2 centuries, Professor Ravi Shankar, and greetings from our institute, Mahatma Gandhi Medical College and Research Institute. So what are the indications of blood gas analysis? What are the indications of blood gas analysis? It seems to be very easy, but to document respiratory failure, assess its severity, yes, to first diagnose the respiratory failure. Number 2, how much is the severity? To monitor patients on ventilator, yes, patients on ventilator, you want to monitor, put a blood gas and see. Now we have assisted. We have put the patient on pressure support. We have put the patient on TPs, assisted weaning, taken a blood gas. To mixed acid-base imbalance. Now the patient is having a metabolic acidosis with the respiratory alkalosis, something like that. The patient is having a diabetic ketoacidosis who is having small respiration and pouring out carbon dioxide and independent respiratory alkalosis. These type of mixed acid-base imbalance. To assess therapeutic interventions, venous blood is not found. Sometimes we cannot find out venous blood. Take an ABG and find out for urea creatinine. Quantifications of the levels of these hemoglobins. Any shock, sepsis, drug overdose, liver, renal failure, COPD, when there is a home oxygen need. For example, previously they used to tell oxygen less than 55, carbon dioxide more than 55. Yes, think of something treatment. These are all the indications. Now we will go to the contraindications of blood gas analysis. A poor collateral circulation, a relatively impaired coagulation. These are all the key things. Burns or distorted anatomy, we can get in some other place. AV fistula, this is very important. Yes, we have to go to the other side. All these things, cellulitis, we have to go to femoral. All these things we should think whenever we are going to sample for a blood gas analysis. But in sepsis, yes, we need to do an ABG because even in the presence of coagulopathy, keep an ultrasound, put in blood gas and take out to find out there are so many problems in sepsis. Now, what are the challenges? PO2 is not the same as content. Now, you see a severely anemic patient may have a normal hemoglobin oxygen content, but PO2 is 95. Think of HB is 3. All these things, yes, whenever you see the ABG, yes, also see the patient and the hemoglobin. We have to tell the patient education and consent for the same, puncture the radial artery, the presence of collateral circulation, artery superficial course, hold local pressure. All these things make radial artery the choice. Yes, I am going to again tell in this how to puncture radial artery in another slide where there is a slide topic is LKG of arterial cannulation. Why not more pulses? Yes, we have to angle like this because pulse may disappear if you keep more than 20 degrees. Small bag here, keep these things and puncture at 35 to 40 degrees. Yes, you will get the blood flow. There are other options like femoral artery, ulnar artery and brachial artery. Already we have told, yes, it is superficial and the collaterals are good, LS test is possible. All these things make radial artery the choice. Problems with other side, poor collateral circulation. Sometimes the brachial artery very close, there may be median narrow. All these things make, yes, we have to think before pricking the other vessels. Yes, we know technique 3 ml heparin slap, hold with left hand, palpate. Yes, palpate for maximum feel. This I will again tell in the next slide. There are so many hiccups in patients with hemodynamic disturbance. The pullback to get blood may not be there. So it may be venous. Get to a limb index and thumb to action. Press edema fluid out. 2 to 3 ml. Remove air. Shift within 10 minutes after you get or 20 minutes. Place in cut ice. Go slow. Tuck sometimes people get, but sometimes if you prick like that, it may go into spasm. So sometimes, If you don't get again, so you may need to go to the other link. Now we will go to the analysis of blood gas. Before going on to all these things, we see we are the right patient. Is the right time? Is the FiO2 mentioned? Is the temperature okay? What is the mode of ventilation? Is the patient breathing spontaneously, normal room air oxygen, or on a ventilator? All these things we have to. Before that, don't check any ABG report. Patient is a 55-year-old female on acidosis. At the time of 3 p.m., we have taken an FiO2 of 40%, normal oxygen venturi mask, and the patient's temperature is 34. All these things have to be put in the mind, whenever you see and read an ABG. Previously, it was Henderson Hasselbalch, which tells only about the bicarb. Now we have Stewart's approach, which tells all the other ions, takes into consideration many ions, and approaches this. Yes, we will go step by step. There are 6-step analysis. Is the pH normal? Is the CO2 normal? Is the bicarb normal? Now then we have to match the HCO3 and CO2. Does they go in the opposite direction? Then when there is an hypoxia. These are all the small 6 steps of analyzing the blood gas. Is the pH normal? pH is normal between 7.35 to 7.44. Is the CO2 normal? It's around 35 to 40. Is the bicarb normal? Around 19 to 24. Match the CO2 and HCO3. All these things are the 6 steps of ABG analysis. Now look at pH. 7.35. Acidemia and alkalemia. Acidosis is the process. This I have already told so many times. Now step 2, analyze the carbon dioxide. If carbon dioxide normally is around 35 to 45, 40 or something like that, it is around 28 means there is an alkalotic. If it is more than 45, it is acidic. PCO2. Then we go to bicarb. Bicarb is around, we know 19 to 24. Below 18, it is acidosis. Above 25, it is alkalosis. Now you see PCO2 is high. Patient is not breathing properly. Bronchial asthma. Now or some foreign body. So PCO2 is high. There is a respiratory acidosis. If the PCO2 is normal and bicarb is low, then it is metabolic. PCO2 is low. All these things have been already told in the last video. Now we know the first 2 steps. It is acidemia, alkalemia, normal pH, neutral pH. The second thing is about it's a respiratory acidosis or a metabolic acidosis. Then you look at the bicarb. If it is below, it is acidotic. If it is above, it is alkalotic. Match either the PCO2 or HCO3 with the pH. pH is PaCO2 is 60. Yes. pH is acidotic. PCO2. Yes, this is what we need to match for knowing. pH is acidotic, PaCO2 is more than 60 respiratory. But HCO3 should be normal, and if it is high, then there is compensation. Movement is opposite. Now we have already told what is Winter's formula. Now we have a metabolic acidosis. Bicarb is low. For that, what is the respiratory compensation? Metabolic acidosis, respiratory alkalosis. The PCO2 is washout. If the PCO2 is washout, if the PCO2 is higher, then there is an associated respiratory acidosis also. How to find out that? PCO2 is 1.5 into bicarb plus 8. If it is more than that, then there is an associated respiratory acidosis. A metabolic acidosis, this is the compensation is Winter's rule. 1.5 bicarb plus 8. 1.5 into bicarb plus 8. 1.5 into bicarb plus 8. Or PCO2 in metabolic alkalosis, 0.7 into bicarb plus 20. 0.7 into bicarb plus 20. This is an acidosis. This is an alkalosis. This is what it should rise. An acute respiratory acidosis, how much is the thing? HCO3, 24 plus actual PCO2 minus 40 divided by 10. Chronic, yes, there is already some compensation. Acute respiratory alkalosis, 24 minus this is a formula. So this is what we should know. Yes, one by one, I will again clear and tell you. There is another metabolic acidosis situation. ABG result is showing PCO2 of 32. Now what is the 1.5 into bicarb plus, that is 22.5 plus 8. This should be the normal PCO2. If the PCO2 is like this in a metabolic acidosis, there is no primary respiratory problem. Now the N is sick. 1.5, bicarb is 15, 22.5 plus 8, 32 it should be. But if the PCO2 is 42, there is a mixed respiratory problem. Again, I am telling you, there is a metabolic acidosis. The bicarb is low. How much is the PCO2 compensate? If the PCO2 compensate by washing out carbon dioxide, it should be 32 because 1.5 into 15, that is 22.5 plus 8, that is around 32. If this itself is 42, then this compensation is not there. Other than that, there is one more respiratory acidosis. There is a metabolic acidosis and an individual independent respiratory acidosis. Now we have already told delta gap. Delta gap is anion gap minus 12. Okay. Delta gap is minus plus carbon dioxide is 22 normally. Okay. If it is more than 26, additional metabolic alkalosis. If it is less than 22, additional non-anion gap metabolic acidosis. In a patient with metabolic acidosis, we were already doing only thinking about bicarb. Now we are taking into other ions. That is what is the concept of Stewart's approach. Take in other ions, find out the delta gap, find out the anion gap, take in chloride, all these things to find out there is an associated metabolic alkalosis or an associated non-ion gap metabolic acidosis. Now we have check it again. Sodium is 145, potassium is 4, chloride is 101, bicarb is 50. There is a metabolic acidosis. What is the anion gap? Anion gap is sodium plus potassium minus chloride plus bicarb. We know bicarb is 15. Chloride is 101, something like that, sorry. 145 plus 4. This is 29. Take this as 105. Now delta is equal to, gap is equal to anion gap minus 12. 29 minus 12 is 70. That is delta gap. If delta gap plus bicarb, what is the bicarb? 50. That is 32. 32 is more than 26. There is an additional metabolic alkalosis. This is what is the importance of knowing the SID and Stewart's formula. Now, if you don't know, we will think only that is a metabolic acidosis. Yes, but here, as we have found out the delta gap, now you see again, anion gap minus this thing. Delta gap, right? Delta gap, anion gap minus 12. Again, you see, delta gap is equal to anion gap minus 12. Delta gap plus bicarb is equal to less than 22. Then it is additional and non-enagma. If it is more than 26, there is an additional metabolic alkalosis. Here there is a more than 26 additional metabolic alkalosis. There is an acidosis because bicarb is 15. There is an acidosis metabolic because bicarb is 15. There is an additional metabolic alkalosis because your delta gap is plus bicarb is more than 26. Additional metabolic alkalosis. Now, 6 is simple. Hypoxia is there or not there? Less than 60, saturation less than 90. The PaO2 rises with increasing FiO2. All these things are only for room air. If the patient is giving oxygen 40%, then 60 is abnormal. So normal PaO2 divided by FiO2 is more than 400. It is confusing. So that is the simply multiply by 5. FiO2 is 40%. 40 into 5. How much it is? 200. This 200 is the normal PaO2. Normal FiO2 is 21. Multiply by 5. 100. If that is not there, then it is hypoxia. Don't think just because we have 90 PaO2, we are normal. If your PaO2 is 90 on 50% oxygen, 50 into 5, it should be 250. But your PaO2 is only 90. So that is what is hypoxia. FiO2 into 5. That should be there, your PaO2. Strong ion difference is the difference between positively and negatively charged strong ions. Already I have told this cation concentration. Now we know the strong ion is 6.1 plus SiID ATOT divided by 0.03 into PCO2. Previous pH was how much? Only bicarb by carbonic acid. Now we see SiD minus AT. This is what is the difference between strong ion induced pH and also the previous bicarb Henderson Hasselbalch. There is a difference between venous blood gases. pH will be little lower, the PCO2 will be little higher, and bicarb will be little higher. This is something in the pH of venous blood gases. The capillary blood gases may slightly change in shock states. That is very important. Otherwise, it is similar. Bicarb is slightly higher and pH is lower. But yes, in shock states. Now we will go to the examples. Now we have so many things. Strong ions, anion gap, delta gap, estimated Winter's formula bicarb. What is the normal PCO2? All these things we have now put. We know what is to be analyzed like. Now we have an example. pH is 7.3, bicarb is 18, PCO2 is 38. This is some case. PO2 is 58. Now there is an acidosis. Bicarb is little less, so metabolic acidosis. What should be the thing? 1.5 into 18 plus 8. 1.5 into 18 is 25. Okay, or 27 plus another 8 is around 36. Right? We'll see. Acidemia, metabolic acidosis. Winters, there is some respiratory problem because 18 now 1.5 into 18 available. 18 plus 27 plus 8, it is only 35. Approximately, your PCO2 should rise only to 35 for compensation. More than that, it is going on. Compensating is not possible. There is an individual small respiratory acidosis because PCO2 is higher. I'm coming back again. 7.3 is the pH, so there is an acidemia. Bicarb is less, there is a metabolic acidemia. So bicarb less acidosis, then the PCO2 should be less. So 40 less. But it should be how much? 1.5 into bicarb plus 8. 1.5 into 8 plus bicarb is only 35. But it should go to 35. It is 38 means there is also some respiratory acidosis. Increased anion gap. 141 plus potassium. 145. Now minus chloride plus bicarb. See, there is more than 12. So that is increased anion gap, metabolic acidosis with some respiratory acidosis with hypoxia. Now you see again, we have an hypotensive shocked patient. Patient is conscious. pH is 7.2, PCO2 is 27, bicarb is 11, sodium, potassium, glucose, PO2 is 78 on FiO2 of 30. 13, how much it should be? Into 5, 150. But PO2 is 78. So we will go from step 1 to step 1 pH, acidemia. Here you see metabolic. Yes, metabolic. Because PCO2 lesser than it should be alkalosis. But here it is acidosis. So metabolic acidosis. How much should be the compensation? How much should be the compensation? 1.5 into 11. How much it is? 11 plus 6.5, 17.5 plus 8. So it is 26. So there is no extra compensation. But still it is increased anion gap. Why? Sodium plus potassium minus chloride. Example, if you see, it is around, sodium is 131 and chloride is how much? 90 plus 7, 111. So it is around 20. Anion gap is increased. 8 to 11 is the normal anion gap. 131 plus potassium, maybe 4. You take is 135. Here you take this, add this, 90 plus 7, 101. 135 minus 101 is 34. See here. What is the normal? 8 to 11. So increased anion gap, metabolic acidemia with ideal respiratory compensation. There is no mixed other respiratory compensations. Step 1 acidemia, PCO2 is low, metabolic acidosis, increased anion gap acidosis. Now is step 4, compensation. What is the delta gap? I have already told, plus 11 is equal to 28. This is more than 26 means there is a metabolic alkalosis. See here, the same thing. If you apply this formula, you are finding out an extra metabolic alkalosis because this gap should be 22 to 26. If there is less than 22, there is an additional normal anion gap acidosis. If there is more than 26, it is additional metabolic alkalosis. Now you see, hypoxia, increased respiratory acidosis, respiratory compensation is fine. There is an additional metabolic alkalosis because delta gap is more than 28. Hypoxic, increased anion gap, metabolic acidosis with some respiratory compensation with concomitant metabolic alkalosis. With hypoxia, I've already told. Now again, go to the 6 steps. pH is normal? No, acidosis. PCO2? Yes, which is very less. Bicarb is less. So it is a metabolic acidosis. Acidosis, metabolic acidosis. What should be the compensation now? 1.5 into bicarb plus 8. 15 plus 8, 23. Slightly PCO2 is high. Now we see 129 minus 109. Add this. So it's around 20. Now you see there is an anion gap is increased. Increased anion gap, metabolic acidosis. Is there an extra respiratory compensation? Is questionable. Hypoxia. Now we will go to the other thing. Step 1, acidemia, metabolic acidosis, anion gap, increased anion gap. Now you find out the delta gap. Delta gap is 8 plus 18, only 18. It should be 22 to 26. Then there is a non-anion gap metabolic acidosis also in this case. We have forgotten, if you have forgotten to find out the delta gap, then we are in for a soup. We are not finding out there is an extra nagma in this case. Hypoxia, increased AG acidosis, normal respiratory compensation with an extra non-anion gap metabolic acidosis. This is what we should think in this case. I think it is circuitous in the head. Go on doing this exercise. Yes, you will remember lifelong. Increased metabolic acidosis, insufficient respiratory compensation, a different nagma. Anion gaps will come into play in metabolic acidosis. Now a case of CRF with dyspnea, acidosis. So metabolic acidosis. PCO2 is how much it should be? PCO2 is 1.5 into bicarb plus 8. 16 plus 8, that is 24 plus 8, it should be 32. It is a little less. What is the anion gap? 131 minus, it is also high. Plus bicarb, no, 116, 130 is around 15. Now you wait. Step 1, acidemia. Step 2, metabolic acidemia because the bicarb is low. Now this is respiratory alkalosis is compensating. Now, what's the delta gap? 40. Same acidosis. What's the delta gap? Yes. So it is 21. Less than 22, there is a small nagma. It's 22, it is okay. Now we get severe acute asthma, 7.29. See, 3.5 milliequivalent rise in bicarbonate expected 10. Where bicarbonate, if it goes 10, then the PCO2 should increase by 4. The normal compensation. See here, PCO2 is 7.1 acidosis. PCO2 is 60 respiratory acidosis. Now the bicarb, step 3 compensation. What should be the bicarb? Normally for 10, 40 and 20. That should be a 3 to 5 increase, 8 increase. It is okay. Compensation is there. Not much extra compensation. This is what I can say. Now you see anion gap is normal. Your delta gap is 26. Yes, delta gap is equal to plus bicarb. This has to be added. Anion gap minus 12, 1 plus bicarb. This is a delta gap. That is 26. Anion gap minus 12. That is plus bicarb. That is 26. So 22 to 26 is okay. There is not much of extra metabolic alkalosis. We are having a case of acute asthma where the PO2 is only 58. Patient is hypoxic, going for a type 2 respiratory failure and respiratory acidosis. Compensation is adequate. There is no mixed acid-base disturbance because your delta gap is only 26. Hypoxic uncompensated respiratory acidosis because pH is 7.29. Acute respiratory, your PC, what is the expected bicarb? Accepted bicarb is 24, 26. Now we have 25. So expected bicarb is 24 plus actual PCO2 minus 40 by 10. Actual PCO2 is 60 minus 40 by 10, 20 by 10, 24 plus 2. That is the bicarb. Now we have 25. Now we don't have 20 to find out there is an extra acidosis. We don't have 45 to find out an extra metabolic alkalosis. We have exactly the same thing. It is uncompensated respiratory acidosis. A case of persistent vomiting. pH is 7.4, neutral pH. So everything is fine, I think. 31, you see here. pH is 7.4, 31. PCO2 is 42, PO2 is 90. This is, now you see, neutral pH. Metabolic alkalosis, well compensated. Normoxia, anion gap is 18. 18 minus 12. Here we have anion gap of 18. Minus 12. That is 6 plus 31, 37. We have what is that we have? 42. Expected PCO2 in metabolic alkalosis can also be calculated like this. So an additional metabolic alkalosis. If it is more than 26, metabolic alkalosis. This is also clear. Expected PCO2 in metabolic alkalosis. So it is a case of metabolic alkalosis which is compensated. Thank you very much for the